What about pulmonary function testing? This is one of the cornerstones of diagnosis of patients with interstitial lung diseases and actually patients with respiratory complaints at all. In general, this should include full pulmonary function test, including spirometry, lung volumes, diffusing capacity, or DLCO, and we usually do a pulmonary arterial blood gas with this as well. The pulmonary function testing pattern seen in interstitial lung disease usually reveals a restrictive pattern with a reduced DLCO. Early in the course of the disease, however, the only abnormality may be a reduced DLCO, and it can be seen to be out of proportion to the remainder of the pulmonary function tests. Obstructive defects can be seen in some interstitial lung diseases, including sarcoidosis, pulmonary Langerhans cell histiocytosis, LAM, hypersensitivity pneumonitis, and silicosis. Interstitial lung disease, of course, can occur in patients with established COPD or obstructive lung disease, and then it becomes sort of tricky. These patients can have both obstructive and restrictive features, and they may even have normal lung volumes, but the DLCO will likely still be quite low because, again, they have two processes now instead of one. So some of the findings of restriction can be overcome by their obstructive physiology, but again, their DLCO will be low. I don't know how well this projects, but this is a patient of mine he's still with us, has IPF, and I actually initially saw him back in January of 2008, and you can see on his pulmonary function test that his spirometry is normal. His lung volumes are normal as well, but his DLCO is moderately reduced when corrected for hemoglobin at 41% of predicted, and that's out of proportion to the remainder of his pulmonary function testing. He actually had typical radiographic findings as well, even at this time. Unfortunately, this patient, he was a very 74-year-old guy who was otherwise very healthy. I actually sent him down to Dr. Lloyd and Company for consideration in a trial, and he was actually thought to be too early along at the time. When I saw him 6 months later in July, he had taken a little bit of a drop, but nothing terribly major on spirometry. On his total lung capacity, though, it had dropped from, if you recall, 6.53 liters down to 5.13 liters, now down into abnormal range. It was 88% of predicted, now 69% of predicted. His DLCO actually had increased a little bit. Unfortunately, about a week after I got these pulmonary function tests, the patient was admitted to the hospital after falling. He actually sustained a fracture of his hip and of his, one of the bones of his forearm, and had horrendous pulmonary infiltrates. And Jim, I actually asked you about this guy. Just terrible diffuse bilateral pulmonary infiltrates. We did bronchoscopy on him and eventually did treat him with steroids, although there was really no evidence of any infection, and there's no evidence that steroids help. But in retrospect, I think this guy probably had an acute exacerbation of IPF, and now he's essentially wheelchair bound. These are his tests 3 months after that. His spirometry is severely reduced. It's now in the moderately severe range. His total lung capacity is 58% of predicted, and he couldn't even do a DLCO. If you look at his flow volume loops between January of 08, when I first saw him, and October of 08, you can see that his pattern has become a lot more restrictive, and his lung capacity is decreased by about 2 liters. So he's taken a big hit just in 9 months. And this next slide just shows sort of the progression of, again, of his decrease. So this can be a really terrible disease, and patients can deteriorate very rapidly. So what about, I just talked to you about some of the pulmonary function tests and gone through some actual patient PFTs, but these are some of the physiologic patterns seen in IPF on pulmonary function testing and in other tests. The forced vital capacity generally decreases but can remain the same. FEV1 to FVC ratio increases or remains the same. DLCO drops. Total lung capacity generally drops as well, but may remain the same. And the difference between the alveolar and arterial oxygen partial pressure during exercise increases. So the typical findings, just to summarize in IPF, is restrictive picture with impaired gas exchange. Normal resting pulmonary function tests do not exclude IPF. And again, DLCO can be reduced early. And desaturation on a 6-minute walk test can help you go in the right direction as far as diagnosis. Let's switch gears and talk a little bit about chest imaging, radiographic patterns. The first test often ordered for any respiratory complaint is a chest x-ray. And classically, before CT scan, this was the imaging modality that was used to diagnose and classify interstitial lung disease. Now this has largely been supplanted by CT scan, particularly high-resolution CT scan of the chest, which we'll talk about in a minute. It's interesting to note that 10% of symptomatic patients who are eventually diagnosed as having an interstitial lung disease will have a normal chest x-ray. Consideration and exclusion of other causes of pulmonary disease is obviously necessary, and CT scan, particularly high-resolution CT scan, is useful in patients with a normal chest x-ray who you still think may have an interstitial lung disease. On chest x-ray, the interstitial lung diseases are typically divided into interstitial opacities and alveolar filling disorders. A lot of interstitial lung diseases present with both types of findings, and you can have a mixed radiographic pattern. So this is a chest x-ray that, I don't know how well it projects or how well it's reproduced in your handout, that actually shows typical alveolar filling pattern. You see just large infiltrates. They don't particularly appear reticular or linear, and they have an alveolar pattern. You can't see air bronchograms too well, but that's what you would expect to see in an alveolar filling pattern. Interstitial opacities are usually caused by expansion of the interstitial compartment, and that can be due not just to fibrosis, but also due to edema, smooth muscle proliferation as seen in LAM, granulomatous changes as in sarcoidosis, and tumors, lymphangitic spread of tumors. And the resulting infiltrate is interstitial, and it can be nodular or linear in appearance. And in any given patient, usually you see both types of findings. Nodules can range in size between 2 to 3 millimeters up to 10 millimeters. And nodules in interstitial lung disease are commonly seen in sarcoidosis, silicosis, Langerhans cell histiocytosis, and berylliosis, which sometimes can mimic sarcoidosis. Linear or reticular interstitial infiltrates occur with a wide range of interstitial lung diseases and are actually quite nonspecific. Honeycomb changes, however, that produces a more specific reticular interstitial pattern and is usually associated with underlying UIP, or usual interstitial pneumonitis, which is the pathologic hallmark of IPF. It correlates with histologic honeycomb change, and it's indicative of advanced irreversible damage, scarring. It reflects marked disruption of the lung architecture and leads to a formation of a network of collagen bands that form small cyst-like structures. So honeycombing, you can kind of think of a honeycomb from a beehive, and that's a lot of what this looks like, both histologically and radiographically on high-resolution CT. This is a chest x-ray that shows the interstitial pattern. You can see here that you don't really see these big alveolar filling opacities. You see very fine linear and reticular opacities, and that's the interstitial pattern. Again, this can be mixed, and you can see nodular changes on this as well. I really like this slide. It was taken from the pilot slide deck, and it's some things to consider IPF if you see certain findings, including reticular opacities, and they tend to be particularly pronounced at the bases and peripherally. If you see reduced lung volumes and if you see honeycombing, you should consider an alternative diagnosis if you see alveolar opacities, as that first x-ray I showed you, if you have significant pleural disease, if you have significant lymphadenopathy. And again, remember that a normal chest x-ray does not exclude pulmonary fibrosis, particularly IPF.